So hi everybody, thanks for the opportunity to speak today. My name is Phil Pastides. I'm a locum consultant trauma surgeon at Guy's and St Thomas's. I'm going to try and condense years and years and careers worth of notes on revision arthroplasty to about 10 minutes with a very brief overview, just get an idea of what to expect. So the reason for revision arthroplasty is typically a painful arthroplasty. And the first thing that we have to do as surgeons is try and work out what the reason for that is. And it's a multifactorial problem. And the key is to make the right diagnosis in what is the cause? Why is this patient unhappy? Is it infection? Is it malalignment? Is it loose? Is it coming from somewhere else? Is it neurological? Because unless we find out what the correct diagnosis is, we can't possibly just blindly treat these. The most important differentiation to make is obviously whether there's infection or not. And this really does create polar opposites directions of what we do. So we really need to work out very carefully whether there is infection or not. And I believe there'll be some talks following me trying to clarify the infective side of it. If we do talk about infection, or we're worried about infection, then our treatment options are somewhat limited, but there are some options. The first one is a debridement antibiotic implant retention, the so-called DARE technique. This is one which ideally you want to catch in the acute phase, because the earlier it's performed, the more effective it is, and ideally within a few weeks of diagnosis, really. That's before the establishment of the biofilm is there. And the idea is that you exchange all changeable components and do a really thorough debridement. So this isn't one where you go in with a 6 litre wash and just spray everything. You really have to get in, remove the soft tissue, remove the synovitis, and we must be prepared to do a first stage revision in these cases. So if you do go in and you find that the components are loose, there's no point retaining. They all have to come out, cement blocks go in. So please make sure your patients are consented for this. If we're again talking about either revision, whether it's infection or not, but we consider a 1 or a 2 stage revision. A single stage revision is removal of all the implants and a thorough debridement, just as you would do if you think there's infection, of all of the soft tissues, any loose bone, bone marrow, cement, anything that's there. Properly wash it all out, redrape, restart again, and then you re-implant definitive prosthesis in one setting. Whereas a 2-stage revision is where we remove all of the implants, we do the same thorough debridement, and instead we implant an antibiotic-loaded spacer and then close up. And then the idea is we're leaching antibiotics locally through the cement, but also systemically through intravenously. And we come back and re-implant the definitive prosthesis when we think the infection is resolved, if it ever truly is resolved. Which one do you choose? So there's a lot of interest in doing a single stage revision. It's better for the patient, financially, etc. It's better to get the patient up and moving, but they are quite similar. And this is a recent review article which looked at that. And they looked at 14 systematic reviews and 18 2-stage revisions. They found a similar functional outcome, a similar range of movement. But even if you look at that, the eradication rate is still in the 80s. So despite trying all the best things that we do, we're still having 15% of our patients who come back with an infection at some point. This is some clinical photographs of what a debridement, what a DARE procedure is. So you can see here we've taken out all of the metal components, all of the cement, the plastic button, and scraped out all of the synovium, all the gunky lining. So it's quite a lot of tissue that comes out. The most important thing really is what are the challenges of revision surgery. So the first one is the patient and the family. So you have a patient who's upset, frightened, scared, in pain, really doesn't want to go through more surgery. We have to deal with that and the emotion that it comes with. Bone stock is always a problem. So whenever we remove any metalwork, either an infected or not infected, undoubtedly we're going to take off more bone. So we need to be able to find techniques to improve all of that. We then need to fill up the gap, and it's we have to be very careful to make sure we don't get our joint line too high or too low, because that's going to create tracking problems, ongoing pain and dissatisfaction with the patients. And obviously, if we're talking about infection, the recurrence of infection is a key thing that we really worry about. Remember, we're not talking about the bone. The bone is surrounded by soft tissues. The knee is quite a subcutaneous joint. We've got to be careful of previous incisions, look at superficial and deep structures, neurovascular structures, especially when everything's scarred up, and we're dwelling on the back of the popliteal fossa, and difficulties in exposure. So if we can't revert or retract the patella, do you need to do a quads turn down? Do you need to do a tibial tubercle osteotomy? How are you then going to fix that? What long-term problem is that going to give them? And then just when you think everything's done, you've spent the last hour and a half, 2 hours doing a really nice femoral and tibial component, you think you've got your joint line perfectly, flip the patella back on, you find out it's not tracking. Then you spend another half an hour, 40 minutes trying to get that right. So lots and lots of things to sort of consider. I'm just going to show a few clinical photos just to give an idea of what we can have. So this is a typical thing that we will encounter. This is a patient who came to us for revision surgery. He had a uni that had been revised a few years later due to progression of arthritis to a total knee. You can see that the scar has been curved round and during the midline. He now needed another revision because this was loose. And we need to decide how we're going to approach this joint. We want to use the old scar. You ideally don't want to come straight down the middle. That might give you problems with the skin. So you've got to be prepared and think about this preoperatively. Somewhat more dramatic case. This is a lady who's under our care. She's actually having a second stage revision in the next few days. And she actually has developed a sinus in the popliteal fossa. This is the back of her knee. You can see it's pouring out pus. So this we had to approach from the front and the back. To clear it all out and get things to heal. The other thing is that you need to know your equipment. So with every operation, the most important thing is knowing what you're doing. And you need to have a kit that's modular, that can deal with bone loss, whether you're thinking about augments, metaphyseal sleeves or cones. Are you going to use stems, cemented, lengths, etc.? And at Guidance St. Thomas's, we use the Johnson & Johnson Synthes, the PFC Sigma system, and that takes us all the way through from a simple CR knee all the way through to hinge knees. And here at the bottom you can see these two things which we call sleeves, and they are very good for bone loss in the metaphyseal region. They actually hold in zone 2, and we use them quite routinely, and they are real game changers for us as well. So have a read about them, but they're very good and get you out of trouble quite a lot. The other thing to talk about with the revisions is that gone are the days of each surgeon doing it by himself independently. Now with GIRFT and everything, we're moving into an MDT approach. We run a Southeast London revision MDT every 2 weeks. That's remote access and in-person access. And we have a dedicated team who attend all of these meetings, including microbiologists, plastic surgeons, radiologists when we need it. It's run by guys at St. Thomas's, and it's a great learning experience. But the idea is to share the knowledge, share the expertise, get extra people in to help with each of the cases, and it really does improve patient outcome. So I thought I'd show you a few cases now, being an orthopedic talk, about a so-called simple revision, if there is such a thing. I personally find all revision surgery extremely stressful. But I guess the simpler ones are the ones which are non-infected and have generally a better bone stock. So things like a uni or a PFJ replacement moving to a total knee replacement. Generally, there's a minimal or localized bone loss which you can manage quite simply. So this is a case that we did. So this gentleman had a uni, was doing very, very well for many, many years, but gradually it's worked its way loose. He was revised in a single stage after going through the MDT to essentially a primary knee, but you can see he's got a little augment on the medial side, a little cemented stem just to take us down into zone 3, doing very well post-surgery, no problems. Another example of patellofemoral joint replacement, again, doing very well. Had it for a few years, then started to develop medial-based symptoms with progression of arthritis. You can see here, actually, in this case, even more simple. She was converted to a straightforward CR knee with no use of any augments. So relatively straightforward. Other things to think about is fracture. So when you have a big paper-acidic fracture that can't be fixed, you need to bring in your revision systems, and sometimes this is a good time to get your revision surgeons to come in and do this. This is somewhat of an extreme example, but this was a 94-year-old who had a fall at home. She had a left total knee replacement for 25 years. You can see the radiographs here, quite significant bone loss. No chance this was, you could fix this. So our option here was to do a distal femoral replacement on her. This is what we took out. And then we had to fill the gap with what you can see here. So long stems, sleeves, distal femoral augments, a cemented stem going up into the femur, and a hinge knee. And it seemed to work well for her. When we move on to some somewhat more complex revisions, so we can think about single stage revisions. So another classic example, a 76-year-old, reasonably fit and well, had bilateral knees done 15 years ago, always been a little bit of valgus, but was managing well. But 3 years, for the last 3 years, complaining of some grumbling left-sided knee pain. These were her long leg views. Again, you can see a valgus orientation of both of her knees, and this is what she ended up with in the single stage here. So this is a TC3, so it's not a hinge, it's more of a PS plus. Has a metal post going through its poly. You can see we've got a sleeve here on the tibial side, and just some long uncemented stems going up into the femur. And again, she's done very, very well with this. In fact, she wants the other side doing now. You can see here how we maintain the joint line. We haven't taken off a lot of bone on the tibia, and the patella is roughly where it needs to be. Sometimes you can't do a single stage, you have to do a 2-stage. And this is typically what we would tend to do for infections. So this is a lady with a very raised BMI and history of lymphedema, had a distal femoral fracture with a malunion that had healed many years ago, and a proximal femoral fracture in the intramedullary nail 6 years ago. Was having pain in her right knee for many years and 6 months of ooze, and she was referred to us as a tertiary centre with this, but obviously discharging sinus. These were her radiographs inside. You can see all the challenges posed here from the lateral on the lateral to the intramedullary nailing to the sinus. So she ended up with a 2-stage revision. So we took out all of the metalwork, including the intramedullary nails, put some antibiotic loaded spacers in, left her, let it all settle, came back another day and did a hinge knee replacement for her. And in fact, with the help of a plastic surgeon, we were able to excise that sinus, undermine the skin at stage 1, close the skin, and she required no further surgery. So again, the argument of having a multidisciplinary team approach and having plastic surgeons available for these really complex cases. Sometimes you can't do the knee replacement, so you have to think of something else and do something partially salvageable. So this was a middle-aged gentleman with a knee replacement, which unfortunately got infected and came with a similar-looking pussed out sinus around his tibial tuberosity. And when we took him to theatre, we actually found that he had a rupture of the extensor tendon. He was struggling to straight leg raise pre-surgery, but we thought he might be able to cobble something together, but unfortunately it was completely gone. So he ended up having a arthrodesis, so a femoral tibial fusion with a long nail with a gastroc flap and a split skin graft done at the same time. The clinical picture on the left shows you what his skin graft looked like at 2 weeks. Then one on the right, see what it's like at 3 months. So he's now completely healed, doing really well, bought himself a scooter and is actually sort of up and down doing some hill walking and now living a good quality of life, but he's managed to keep his leg. Sometimes though you can't be salvaged, and this is the nastier side of the revision work. So this is again a 56-year-old gentleman with a raised BMI. He's had 14 operations to this knee, complicated by a periprosthetic joint infection. He's had two-stage revisions in the past and unfortunately contracted a fungal infection. Came in quite a difficult state, a very limited range of movements. This is what his knee looked like. Unfortunately, this is non-salvageable. He ended up with an above-knee amputation, and he's doing really, really well with a prosthesis. And he's actually sort of saying he wished he had had this done sooner, despite all of his problems. So sometimes we can't always treat, but we're trying to improve quality of life, and an amputation has to be part of our armory as well. So the take-home message is that revision surgery is extremely challenging. It's a periprosthetic joint infection until proven otherwise. So we must rule that out because it really is a completely separate path. We always adopt an MDT approach to all of these now, so please don't be afraid to ask for help, refer them in to your local units. I'm sure the MDTs will be setting up in revision centres all over the country fairly soon. And they're very challenging cases, both for the patients, and they're physically and mentally draining. But when they do go well and you see a patient walk in a few months after very complicated surgery with a knee that's working, it's not perfect, but it's working, it's relatively pain-free, and they've got good function, it really is very, very satisfying. So the last thing I'd like to say is, please call a friend, don't take these on yourself. It's great work, really challenging, and quite fun to do when you get it right. Thank you very much.